presidential oration by Professor Dr. Vijay. We will felicitate our founding president, Professor Dr. Vijay, and then he will begin the oration on advances in coronary physiological assessment in CAD and CMD.
My pleasure to be here and delivering the presidential oration for our society. And this time I've chosen a topic of advances in coronary physiological assessment in CAD and CMD. We all know that about 30 to 50% of patients with the CAD also have coexisting the microvascular dysfunction, microcirculatory dysfunction. So this becomes very important to talk about both of them together so that we get some concept. What happens is most of the time in our practice we are busy. We look at only coronary arteries, the epicardial arteries, but forget to look at the microvascular circulation, which is 90%. 10% is only epicardial. 90% is microcirculatory. So we must look at it, and the only way we can look at it is do a physiologics testing. So physiologics testing we are doing, no doubt about that, FFR and IFR regularly for borderline lesions. And also sometimes we also do for a lesion which is in the side branch and we think that may not be necessary to put a stent. We can manage with the medical treatment because it becomes otherwise a normal main vessel has to be stented as well. So this is the way, but there are some pitfalls that can happen, and we all understand these pitfalls are very important, but the most important one is drift. We usually don't notice that. So if you see a drift in the pressure cup, then you must go back to equalization and then repeat the whole process. This is a very important. You should not have the ventricularization of the distal pressure. Very, very important. Then coming to that, we have two FFR and we can have a hybrid strategy. Do IFR first, and wherever the IFR suggests treat value, then there is no problem, treat. Defer value, no problem. But in between the two, the gray zone, there we need to go and do the FFR study, which is hyperemia induced, and see whether FFR is positive or not. That is very important. But what do we do for diffuse disease, multiple block, serial block? Every time we cannot keep on repeating, open one block and do again the whole, pass the wire again, the pressure wire, and do the testing. And this, if you have a serial stenosis, then they do crosstalk. And then it's very difficult to, because one underestimates the other one and one overestimates the other one. So this is a big problem. So we have to move on ultimately to something which is real time in the cath lab. As soon as we do coronary angiography, we get idea about the functional testing. And that is called as functional coronary angiography. And there are several parameters which are included in functional coronary angiography: QFR, UFR, QFR, DFFR, FFR, and another one is a micron QFR, which is very highly sensitive and specific and requires less, but then single view can do it. Then FFR CT and that QFFR. So this has become now a gold standard that we have to move on to something which is real time in the cath lab just by doing a software. Is guideline recommending them? Yes. 1A for QFR assessment, 1A for multivessel disease, and 1B for epicardial stenosis. What is this functional coronary angiography? It includes several parameters. And how it is assessed, what is the technology? It's the computer-based, innovative angiography-derived, wire-free method used in coronary catheterization laboratory to assess functional significance of moderate coronary artery disease. And we have vessel FFR and the computational FFR. All these are managed, or technology is basically fluid mechanics with the AI, with the use of the AI, so that you convert 2D images of angiography into a 3D image and get a real-time idea about significance of the lesion. So there is no pressure wire required, less complication, no adenosine, less complication. Speed is very fast, as I said, real-time. But only limitation is, if you do angiography, then you have to do assess the QFR in two different orthogonal view, at least 30-degree apart, and the quality of the angiography should be excellent. So are these validated? Yes, the trials phase 2 and 3 have validated them with FFR, and it's 90% specific and accurate. So non-inferiority testing has been done. The mechanism is very simple. We need a good quality coronary angiography, and there is software already in the cath lab installed, which will assess automatically on real time and tell us. And another advantage is we can also try virtual stenting without doing a PCI and see the result of the PCI, which is very, very new, and I think this is very important for all of us. It is incumbent on us that we provide good result to the patient, not only do the PCI, but long-term good result is very, very important for us. So once you have a distal disease, the software will play, then it will find out whether there is a flow-limiting disease or not, and do a longitudinal vessel analysis automatically, and find out whether the lesion phenotype is focal, diffuse, or mixed of diffuse and focal, and also tell us with the simulation functional PCI whether this PCI will provide good physiological result or not, which will give good long-term result. So this is a very important aspect that we should remember, and if the region, the post-PCI evaluation suggests that it's suboptimal, then we need to optimize it or even do imaging and find out how to optimize it. Now there are 6 studies which have been done post-PCI. With 6 studies suggest that at least 30 to 40% PCI are suboptimal physiological results, which is a large number. We just see on angiography that result is very good and we are very happy, and we just conclude our procedure. So we have to keep in mind that 30 to 40% is a large number. I know all of us nowadays use NC balloon post-stenting and optimize it to the best possible level at a high pressure. That is true. So post-PCI physiological analysis, if optimal functional result, end the procedure. If it is not optimal, then it is stent factor, under expansion, edge dissection, thrombus or plaque protrusion, or it's a vessel which is residual stenosis beyond the stent, vessel dissection. All this we have to see, reassess, and find out if we can correct the physiological anomaly. If it is corrected, no need to do. If it is incorrected, then either CABG or advanced OMT, means advanced medical treatment. Is this QFFR can provide co-registration? Yes. You can see the co-registration on OCT and co-registration on QFFR. It's almost identical, no difference. Now we are talking of virtual PCI. Okay, there's 2 vessel disease, LAD and circumflex. You can see, let me take the cursor so that I can point out clearly. Okay, so you can see the QFR value is 0.50 in the LAD and 0.77, which is both are significant. Less than 0.80 is significant. QFR and FFR have the same cutoff value. And RCA is normal, 0.92. So basically, we don't need to do anything for, and then virtual stenting. Virtual stenting done in both LAD and LCX, and QFR result in both the artery suggests that result is excellent. Okay, then this is what we need to look at it, and look at it in difference. Then real time PCI is done, stenting is done, and again functional testing done on real time by QFR, and the result suggests that it's absolutely good, 0.93 and 0.94. So it's excellent technology, and we should, if we buy a new cath lab, we should try to see that we get this technology. It's only software, I'm sure it may not be costing much. So then this is pre-PCI evaluation. OFR is a new parameter which is very well defined. It is called as optical flow ratio. So if you see optical flow ratio, which is also again a computational parameter through this, and perform a PCI virtually. You can see these 3D images, 1 and 2, and here you can see the stent, and it says there's 2 and 3 level co-registration. The stent needs optimization, okay? Then it is optimized, and you see the OFR was 0.63 to begin with, and it improved to 8.5. And if you see the OCT images, they also suggest that 2 and 3, there's a under expansion of the stent. So this is a very interesting part. I thought we must know about it, all of us. And then if you do a PCI which is angio guided versus a PCI which is QFR guided, clearly you can see the MACE rates are clearly better both in diabetic and non-diabetic patients. And same thing is verified on imaging, intravascular imaging, and whatever is shown as per the QFR is verified by intravascular imaging. And then heart team studied whether QFFR and FFR best equipoise or not, and they were totally equipoise, all the decision, and concurrent totally 90.5, 91.5%, almost 92%, and about 8-9% required some further evaluation. So there are significant advances in the field of coronary physiology. Mind you, these are guideline-based recommendations. As I suggested you and I showed you, these are guideline-based recommendations. So soon I think it is getting validated completely, and soon we will see it in India. In Siemens Cath Lab, this software is already installed. It's ready to use. Now I'm coming to CMD. This is epicardial coronary artery disease. Coming to CMD, we know that CMD is a vast area in which 90% circulation is in the coronary circulation is in the microcirculation. So we can have Inoka, Minoka, Anoka, Takotsubo, iatrogenic coronary artery disease, obstructive coronary artery disease, almost 30 to 50% also have a CMD. So you have to remember that CMD becomes a very important parameter, particularly for long-term results, so that we can optimize medical treatment to improve their long-term results. Why do we need to look at this CMD very seriously? Look at the prognostic implication. 4-fold increase in mortality and 5-fold increase in the MACE rate. So in stable and ACS, both, the CMD rates are predominant, but in stable, it's predominantly women who are affected due to stable coronary artery disease. If you see the curve, from 2010, the curve started going down of the coronary artery disease, but now it is again rising. And the main reason for rising is the CMD. Perhaps we have it's related to lifestyle as well. Now we are looking at the epicardial, which is only 10%, and we'll only put our concentration on epicardial, which is more than 90%. And we need, and which 90% circulation gets only less than 5 to 10% attention. So we have to be aware that this is a new kid on the block, and there are now facilities available to diagnose this microcirculation problem by proper testing. And CoroFlow, we all know, is now available in India. We can do this testing. So size of the coronary artery, if it is from 400 to 20 is all microcirculation, up to 10 micron is microcirculation. And what we have is a smooth muscle proliferation in the vessel, thickening of the intima, spasm, and all this together, and even reduced in capillary density, all this together lead to microcirculation dysfunction. Can we make out something about get idea on angiography? If you have a slow flow, that means entry into microcirculation is problematic, having some difficulty. But if you look at blush grade, myocardial blush grade, in normal you can see blushing of the myocardium, but in a patient who's got microvascular disease, there is no myocardial blush grade. That means the entry may be okay, but exit is not there of the circulation, blood that is going into microcirculation, which indicates microvascular dysfunction. Now, are there any non-invasive method? Yes, PET and stress CMR, both can help us in making a diagnosis of the CMD. So, when do we think of CMD? We do angio, normal coronary, normal FFR and normal QFR also, no obstructive disease. So, we do CFR and IMR using CoroFlow. If the CFR is more than 2 and IMR less than 25, indicates there is microvascular dysfunction, then we should do acetylcholine provocation test, because almost 30 to 50% has vasospastic angina as well. So, but on acetylcholine testing, the block which develops, spasm which develops, should be more than 90% to say that it is vasospastic angina which is affecting this. So once we have this clear idea about vasospastic angina, how do we do the acetylcholine testing? That I will explain little more as I go forward with my lecture. Now, coming to how do we test the CFR and IMR on CoroFlow, we just inject a saline, and there are thermistor, proximal and distal thermistor. But the distal thermistor should be positioned at least 1/3, it should cover 1/3 of the coronary artery to get the true thermodilation results, to get the results of the entire thing, the FFR, IMR and CFR. So this is very important that we pay attention to. Plus we can do a Doppler. Nowadays Doppler is also available. I think Boston, Philips has a Doppler study. We can do the Doppler on that, and very easy to do the Doppler, no problem at all. Now, once we have studied based on thermodilution, we'll get the idea whether the index of microcirculatory resistance, IMR, is more than 25, hyperemic microcirculatory resistance is increased, and microcirculatory resistance reserve. All these 3 parameters, and also one more parameter that can be identified with RFR, because RFR is in a diastolic phase wave free. So if you look at the RFR at that particular level, there is hardly any hyperemia at that time. So we get a minimal microcirculatory resistance. And that can also give us idea whether there is, in addition, microcirculatory dysfunction or not. So is acetylcholine safe? Yes, it's very safe. It's tested in 71,566 patients, and it suggests that it's only 0.5% may have some problems. But the higher dose of acetylcholine, which is about 100 to 200 in the LAD and 80 to 100 in the RCA of acetylcholine, to do the testing, we may need to use microcatheter to inject specifically in the coronary artery, because if we inject in the guiding catheter, it may be outside, we may not know, and we may not get a true acetylcholine test results. So there are 5 endotypes of the CMD. One is the structural. As I said, there is intimal hyperplasia and increase in resistance, and typically diabetic microangiopathy. We all been talking. I remember during my MD training also, way back in 77 to 79, we were talking of microangiopathy, diabetic microangiopathy regularly. So microangiopathy, so correction, here the treatment suggested is correction. Correction of the risk factor and small dose of beta blocker, which is coronary vasodilator beta blocker basically, not the blocker. So, and then of course reduce the risk factor. Now coming to functional and endothelial ACE inhibitor, ARB, lifestyle modification, where there is endothelial dysfunction. Of course, statin remains treatment for all of them, and selected patient ranolazine. Now coming to epicardial spasm, of course, calcium channel blocker. The predominantly treatment is calcium channel blocker and nitrates. Microvascular spasm, if it is there, again calcium channel blocker, and also some other tailored treatment that I will talk about. Then there can be a mixed type of endotype, which can be a combination of epicardial plus structural and functional. So if the medical treatment alone may not improve the CMD angina, caused by CMD angina, then we can try EECP, and it seems to be beneficial, and if you see the p-value is highly significant. So, which indicates that definitely EECP has a role here. If we have a CMD with medical treatment, there is no benefit, still there is ischemia, still there is angina, we can try that. Another technique which is of interest to interventional cardiologists is coronary sinus reducing device. What it does, that somehow the other myocardial pressure increases, so microcirculation get compressed. So by deploying coronary sinus reducing device, this defect is corrected, and that improves the diameter of the microcirculatory vessel and reduce the resistance. So this is very useful, and then stem cell therapy also seems to be beneficial in some patients. Now coming to when we have a myocardial bridge, we see that often on angiography. We don't know whether this has any functional significance or not. How do we assess that? Dopamine test we have to do, and do a functional assessment using wire and find out whether if it is less than 0.76, then it suggests that there is a significant functional significance of that myocardial bridge. We can correct that either by the stent. So far we were talking of stent not indicated, correct by stent, but we require a high radial stent strength. And of course CABG and surgical treatment of myopathy. These are the various treatment that we can do. Thank you for your kind attention.